Okay, welcome to the ongoing webinar series of Parent Project Muscular Dystrophy. TPMD is really pleased to provide these for our community. We're welcoming here today Craig McDonald. Craig is a professor and chair of the Department of PM&R at the University of California, Davis. And Craig's going to begin this discussion about the efficacy of eteplirsen or EXONDYS 51 in Duchenne muscular dystrophy and his recent experience with California Medicaid and MediCal. Craig, would you like to get started?
Yeah, that would be great, Pat. Thank you very much, and I'd like to say hello to everybody this morning. This is, I think, an enormously important topic for our patients, and what I'd like to discuss this morning is just some of our recent experiences dealing with California Children's Services and the California equivalent of the Medicaid program, which is MediCal in California. And I'd like to give some information as to what specific information we presented to California Children's Services and MediCal with regard to EXONDYS 51, and also how the talks proceeded and who was involved in those discussions. And where the progress we've made to date, because I think we're very encouraged by the feedback we've received by California Children's Services. What I'd like to do is really present the specific information that we really focused on in the discussions with California Children's Services. I think just to give families as well as potential providers some information as to what sorts of data was presented to them and what discussions occurred. First of all, I think we had to do some education with regard to the leadership of California Children's Services. But fortunately, in our case, the medical director of the California Children's Services, Robert Diamond, is a pediatric intensivist who actually had experience with Duchenne muscular dystrophy, caring for these children in the ICU setting around the time of spinal instrumentation procedures for congestive heart failure exacerbations, and also with other medical exacerbations when the disease had progressed. So he was really quite familiar with how devastating this disease is, but certainly we provided some background information with regard to Duchenne muscular dystrophy and the significant unmet medical need. We also discussed the very well-known natural history of Duchenne muscular dystrophy, the stereotypic pattern of progression, and how we actually are able to predict the pattern of future progression based on the way in which the disease progresses with certain losses of clinical milestones and clinical endpoints earlier in the course of the disease. So, for instance, the age at loss of ambulation has been shown to be very predictive at subsequent age at loss of upper limb function and hand function, and the age at onset of need for mechanical ventilation, and also has been linked to survival as well. In addition, we did some education with them with regard to the current natural history of the disease and the impacts that corticosteroids have had on the disease progression, and really also indicated to them that the types of interventions, the medical interventions, standard of care has been really been well documented in terms of the care standards. PPMD as a advocacy group has done a remarkable job at helping to educate the community with regard to these care standards and the initiation of the Centers of Excellence for Duchenne Dystrophy. We discussed with CCS that glucocorticoids, aggressive management of spine deformity, aggressive pulmonary management, and cardiac management has really had a tremendous impact over the course of the disease, and we demonstrated to them what the effect of corticosteroids have had on these critical milestones, prolonging the time to rise from the floor, to climb stairs, to raise the hand to the mouth and overhead, and to feed oneself. And the effect that corticosteroids have had, and we see these effects over, say, a 1 year or a 6-month clinical trial, but these effects really translate to remarkable changes in long-term disease progression. And we would expect that with exon skipping therapy on top of corticosteroids, we would also see long-term tremendous impact on the age at loss of these milestones, preservation of upper limb function long-term, as well as preservation of pulmonary function. Just to show you some recent examples of this with steroids, this is our latest data on the age of loss of ambulation with all mutation subtypes with Duchenne dystrophy. Those who had steroids greater than a year, a median age of loss of ambulation of 13.3 years, and those that have not had steroids, a median age of loss of ambulation of 9.8 years. So greater than 3 years prolongation in age at loss of ambulation. And in fact, this data from the Synergy Natural History Study actually translates later in the course of the disease. This is actually Kaplan-Meier survival data on the age at which patients will actually progress to a forced vital capacity of less than 1 liter as adults. Comparing those in the red who've been treated long-term with corticosteroids and those in the blue that have not had corticosteroids. And what can be seen, the progression of forced vital capacity to less than 1 liter has actually been shown to be perhaps the best predictor of 5-year survival in Duchenne muscular dystrophy, with a median survival of only about 8% when the forced vital capacity falls below 1 liter. That was old data that was published in 2001, but we know this is a very relevant predictor of survival. And in fact, patients that have been treated with steroids actually have about a 3-year prolongation of time to a forced vital capacity of 1 liter. So it not only translates to 3 years of prolongation of disease progression around the time of age of loss of ambulation, but it also translates to about 3 years prolongation of disease progression in adulthood in Duchenne muscular dystrophy as well. And so we wanted to really educate the leadership of California Children's Services that these changes we see short-term with exon skipping treatments are likely to translate long-term to prolongation of upper limb function, pulmonary function, and also survival as well. This is just some recent data published from Schramm on the left, actually showing all-cause survival in patients treated with steroids and those not treated with steroids. And in fact, the actual survival has actually been demonstrated to be improved in those treated with steroids versus those not treated with steroids. So this was really initial education that we did with the California Children's Services leadership. And then finally, just noting that ventilation currently has been the predominant factor affecting long-term survival, with prolongation of survival by over 10 years in those that have had standard of care initiation of non-invasive mechanical ventilation by bi-level ventilation at nighttime. We then moved into the development rationale of EXONDYS 51. We discussed the clinical development program. I'm not going to get into the pharmacodynamic data in terms of dystrophin production that we presented to them, but we really did focus not only on that, but also the clinical efficacy data as well. So we discussed the rationale for eteplirsen development. Obviously, patients with Duchenne have adafran deletions with little or no dystrophin. a severe phenotype in patients with Becker dystrophy with in-frame deletion, an internally shortened dystrophin, and generally a mild phenotype. And obviously the dystrophin levels have been far-ranging in the Becker population, but we did indicate to California Children's Services that in recent experiences, very low levels of dystrophin have been shown to provide clinical benefit. For example, as an experiment in Nature, patients with exon 44 mutations have generally a clinically milder phenotype, but these very low levels of dystrophin have shown to have tremendous impact long-term. And just as an example here, the data on the left, actually from our Synergy Natural History Study, shows the age of loss of ambulation in those patients with Duchenne dystrophy who have exon 44 skippable or amenable mutations, both on steroids and not on steroids. And you can see really quite strikingly that those that have this type of mutation that have a very low levels of dystrophin due to naturally occurring exon skipping and revertant fibers. So these are very low levels that might be analogous to those we see with pharmacologic exon skipping. These patients have prolonged ambulation, with 50% of patients ambulating out to age 20 in comparison to those who have other deletion types. And in fact, on the data on the right shows the differences in progression of the North Star Ambulatory Assessment, which is a very clinically neat outcome measure in Duchenne dystrophy, which focuses on very Duchenne-specific activities that are functionally relevant that actually are lost with progression of the disease. And you can see with these very low levels of dystrophin in the exon 44 group, these patients don't tend to progress on their North Star Ambulatory Assessment over the course of 2 years. We then discussed Sarepta's clinical development program. Most of their data that's available has come from their studies 201 and 202, which have follow-up as long as 4 years. We also indicated it was very important for us to let the payers know, the MediCal CCS leadership, that there were additional studies that would be bringing additional data forthcoming in the very near future that would allow an ongoing assessment as to the effectiveness that we see with these therapies, the patient populations that perhaps benefit from the therapies most, and also the adverse events and side effect information that will be important as we get more and more data from clinical use of EXONDYS 51. You're all familiar with the pivotal study 201-202 study design. The patients initially were randomized to 30 milligrams per kilo per week versus 50 milligrams per kilo per week as a IV infusion, and then the placebo patients were then randomized to continue on either 30 milligrams per kilo per week or 50. And then these 12 patients then were followed for 4 years, and data was compared to external control data. So again, just to remind the group with regard to the enrollment criteria, the age of enrollment was 7 to age 13. I think one of the questions that the California Children's leadership had is, what data do you have that is available on younger patients? And there actually is quite a bit of safety data that's been obtained now from the study 203 and study 301 from Sarepta, and there have been patients that have been dosed as young as 4 years of age. And the clinical neurologists and neuromuscular clinicians that discuss this ahead of time were actually very comfortable treating patients at age 4 and above, because there's actually quite a bit of safety data that's been obtained. Sarepta does actually plan on conducting some safety studies in patients younger than age 4, so those patients will be able to participate in those future safety studies, but there's no data yet to present to leadership and third-party payers with regard to the safety, and there's also no data that we can actually demonstrate to families who are considering this therapy in, say, a 12-month-old or a 2-year-old. The 6-minute walk distances range from 180 meters to 440 meters. We discussed with CCS the clinical endpoints, and we did need to do some education with them with regard to what is the 6-minute walk test, why is it important in Duchenne muscular dystrophy, how does it help us predict disease progression and natural history, and we also did some education with them with regard to RT-PCR and the dystrophin quantification approaches that Sarepta has really helped pioneer and bring into the forefront in Duchenne dystrophy. We also did some education with regard to the North Star ambulatory assessment measure, as well as the time function tests that have been shown to be predictive of future disease course, the standing from supine or rise from supine test as well. Now, I'm not going to get into a lot of the pharmacodynamic data, but we did actually present the pharmacodynamic data that Sarepta did present to the FDA as a basis for the accelerated approval, with the emphasis on the multiple methods which have confirmed de novo dystrophin production. And then we focused on the early clinical results, and we initially discussed the results from study 201, where there was encouraging results with patients that had higher baseline levels of 6-minute walk distance, actually maintaining their ambulatory function over the first 48 weeks. There were 2 patients that had more impaired ambulation who actually you would not have expected to see dystrophin production until 24 weeks. They actually did lose some ambulatory function, so we did need to explain that to the leadership from MediCal. We also discussed the study design for study 202, which again allowed 4 years of long-term follow-up data in comparison to the external control group from Italy and from Belgium. With regard to the external control group, we discussed where those external controls actually came from. The International DMD Working Group and the Collaborative Trajectory Analysis Project are ongoing efforts as well. Of the databases which were available, there were 2 that met the criteria. The Synergy database did not have enough long-term data, but the data from the Italians and from Natalie Gomez from Belgium actually allowed the development of an external comparison group. Again, there were patients that were initially selected for possible inclusion as external comparators. This database was mine. Patients were actually treated at these 2 centers with excellent care and care standards. These were leading neuromuscular clinics. They had standardized assessment on the 6-minute walk test and other evaluation methods similar to the EXONDYS 51, the eteplirsen treated patients from the trial. There were inclusion criteria that were utilized very similar to the trial participants for the external control patients. And for the primary analysis, ultimately 13 patients who were exon 51 skippable actually were used for the analysis. These patients actually were very similar to the eteplirsen treated patients in terms of their age, their 6-minute walk distance at baseline, the mutations which were represented. The patients, in terms of the steroid treatment, they were actually more aggressively treated than the eteplirsen group, with 70% of the patients receiving greater than 90% of the recommended dose, and in comparison to only 17% of the eteplirsen treated patients from Nationwide Children's. There were very minor differences in the steroid regimens, which we discussed. But again, it was shown that really the steroid regimen itself, whether it was continuous or intermittent, really didn't impact the disease progression in that external control cohort. They received actually higher level of physical therapy intervention than the eteplirsen-treated patients from Study 202. So we discussed that as well. And in fact, when you compare the behavior of these external controls in comparison with the placebo-treated patients from the exon 51 drisapersen study, the patients actually behaved in a very similar fashion. And then finally, we discussed the clinical results in terms of 4-year prolongation of ambulatory function, the 6-minute walk distance results, 3-year data on the North Star and ability to rise, and then also treatment expectations with regard to delay in DMD disease progression. The 4-year data actually showed about 162-meter benefit at 4 years with the eteplirsen-treated patients versus the external control group. We know that's clinically meaningful. If you actually look at the individual trajectories of the patients, there's quite a number of the blue lines here, which are the eteplirsen-treated patients that are showing prolonged ambulatory ability 4 years out, whereas the vast majority of the external controls have lost the ability to ambulate over this 4-year period of time. We actually showed data on the proportion of patients that actually had preserved ambulation. 85% in the external control had actually lost ambulatory function versus only 17% in the eteplirsen-treated patients. This is the cumulative percentage of patients that had lost ambulation. And then finally, when we compare it to another external control group, the Synergy exon 51 amenable patients, it again appears that the eteplirsen-treated patients were behaving differently than both the external control group from Belgium and Italy, as well as the 32 Synergy exon 51 amenable patients who were on steroids. So we presented that data as well. Now, with regard to supportive endpoints, the North Star ambulatory assessment, which is a Duchenne specific measure, actually there was about a 2.4 point change benefiting favoring the eteplirsen-treated group in comparison to the external control group. We know that's a clinically meaningful change from recent studies that have been published and have come out. In addition, in terms of rise to floor, we know that the loss of ability to rise from the floor, stand from the floor, is prognostic of inability to ambulate in the future. This is Synergy data showing that a much higher percentage of patients that have lost standing ability altogether actually will be predicted to lose ambulation in comparison to those patients that have rise times of less than 10 seconds. And in fact, if you look at the eteplirsen-treated patients, a much higher percent continue to be able to rise from the floor over 3 years' time in comparison to the external control group in terms of that ability to rise independently over time. And then, so I think to summarize, really the efficacy was established by multiple endpoints. Again, it's a small cohort, hence the accelerated approval mechanism was utilized based on a biomarker. But this was really the first therapeutic to demonstrate unequivocal increase in dystrophin following treatment. The external control was an appropriate comparator representative of other natural history databases. There was a dramatic effect size on the 6-minute walk test and on loss of ambulation, and consistent support for eteplirsen benefit on other measures such as the North Star ambulatory assessment, ability to rise from supine, as well as in comparison to the external control patients. So just to remind the audience, if you actually prolong the age at loss of ambulation, this actually has an effect on in terms of loss of pulmonary function in the future. And this is actually natural history data from France that actually demonstrates that, showing on the left the percent predicted forced vital capacity in those that lose ambulation after the age of 11 versus those that lose ambulation before the age of 8. And you can see different trajectories there. And in fact, on the right, the absolute forced vital capacity, patients actually take a longer period of time to reach a peak forced vital capacity with a later loss of ambulation in comparison to those that lose ambulation before the age of 8. So this really demonstrates that if you can prolong age of loss of ambulation and slow disease progression early on, that can really be predictive of subsequent disease course in terms of other endpoints such as loss of pulmonary function. Recently, PTC, I think, utilized the comparison with this type of analysis with an external control, the Synergy natural history patients, and actually the age at which peak vital capacity was achieved and the trajectory started in a downward trajectory was actually prolonged by about 3 to 4 years with adalimumab treatment, and the EMA actually found that to be a very compelling, and I think one of the reasons why they've extended the marketing approval for adalimumab in the case of the stop codon read-through compound. So with that being said, we do have natural history data from other history cohorts showing the loss of percent predicted forced vital capacity by age. The red bars here actually show the loss with patients treated with steroids. The blue bars are those that have not been treated with steroids. And on average, patients lose about 5% per year based on large natural history cohorts. And in fact, with the eteplirsen-treated patients, data showed stabilization of percent maximum inspiratory pressure, percent maximum expiratory pressure, and also about a 2.5% reduction in percent forced vital capacity per year versus a 5% reduction in most of the natural history cohorts. So I think this also suggests that eteplirsen is having impact on pulmonary endpoints as well as ambulatory endpoints such as the 6-minute walk test and the North Star. And I think this was very important for the MediCal leadership to hear, and also provides rationale for the potential usefulness of this drug in non-ambulatory patients as well. Now, there are a number of confirmatory studies that are actually in progress right now. So I think it was important for the California Children's Services leadership, MediCal leadership, to hear that there is additional data that's going to be forthcoming. And also there will be additional data that will be forthcoming from patients that will actually be treated from commercial drug as well, because I think various people will be actually following these patients over time with objective parameters, and the hope is that there will be some form of natural history follow-up or registry of these patients, and that might be obtained in different regions. So there are confirmatory studies that are on the horizon. Again, 2 studies in particular: the Primeau V Study, which is eteplirsen versus an exon, an untreated comparison group of non-exon 51 amenable patients. The EXONDYS study is on the horizon, and then Sarepta also plans additional placebo-controlled studies as part of their agreement with the FDA for their accelerated approval. Primeau V, again, is an open-label eteplirsen trial versus comparing outcomes with untreated patients amenable to exon skipping. This trial is still in the process of being enrolled, but enrollment has progressed nicely, particularly with the treatment cohort. The EXONDYS trial is underway as well, comparing exon 53 and exon 45 skippable patients treated with Sarepta's agents in comparison to placebo groups. So there'll be useful data with regard to proof of concept of exon skipping. We had a discussion with CCS as to which patients could benefit from EXONDYS 51. And we discussed really what's the current data available, whether there's a good theoretic rationale available for a given population, and also cases where perhaps there's more data that's necessary in terms of safety and efficacy. So one of the pieces of information we actually discussed among the neuromuscular specialists in California was perhaps developing some criteria or suggested criteria for California Children's Services as to which patients could potentially benefit. And I'll present some data to that effect momentarily, but just to remind you, the Brook Upper Extremity Functional Scale is one that's very easy for a clinician, regardless of their practice setting, to administer to a patient. And just to remind you, a Brook 1 patient can actually fully reach overhead or abduct their arms in a full circle and touch their arms over the head. A Brook 2 patient can raise their arms above the head, but only by flexing the elbow. A Brook 3 patient has actually lost the ability to raise the hands over the head. A Brook 4 patient is still able to raise the hands to the mouth, but has lost the ability to raise an 8-ounce glass of water to the mouth. So when you weight the extremity, they can't get the hand to the mouth. A Brook 5 patient actually cannot raise the hand to the mouth, but still can use the hands to, say, hold a pen or pick up pennies from the table or use some sort of adaptive technology, such as a wheelchair joystick. And then finally, a Brook 6 patient cannot raise the hands to the mouth and has no useful function of hands and is unable to really access adaptive technology with their hands. And so we actually thought this was a useful, clinically relevant scale to actually begin to give us some thought as to which patients might still be able to benefit in terms of preservation of hand function, which is extremely important, and preservation of upper arm function. In addition, when you look at the data from the Synergy Natural History Study, this is actually data on over 3,000 observations from the Synergy Natural History Study, showing the relationship between percent predicted forced vital capacity and the Brook score. So just to remind you, a transition from a Brook 2 to a Brook 3, you lose overhead reach. Transition from a 4 to a 5, you actually lose the ability to raise the hand to the mouth. So a Brook 5 patient cannot raise the hand to the mouth, but they still have useful hand function. And then finally, a Brook 6 patient has no useful hand function present for use of adaptive technology. And when we look at our Synergy data, there's a striking linear relationship between pulmonary function, percent forced vital capacity for age, and the Brook score in Duchenne patients. And when you start looking at Brook patients at Brook levels of 5 and 6, what's really quite striking is that in a Brook 5 population, there are really quite a few patients that have forced vital capacity less than 30%. Some of them will have forced vital capacity above 30%. But when you start to look at forced vital capacity levels in a Brook 6 population, the vast majority of those patients all have forced vital capacities less than 30% in a Brook 6 population. So the neuromuscular clinicians began thinking, well, if this drug could potentially maintains some degree of pulmonary function. Just to remind people, a forced vital capacity of 30% is generally the threshold for the need for mechanical ventilation. But if the goal is to preserve either pulmonary function or hand function, it might make sense to perhaps use this forced vital capacity level as well as the Brooks score as potential criteria, really giving patients the benefit of the doubt that there may be patients who are Brooks 6 who still may have some preservation of pulmonary function. There may be patients who are Brook 5 patients that might be below 30% on a forced vital capacity. And so what we actually decided as a group that if either forced vital capacity was above 30% or the Brooks score was a 5 or better, that those would be patients that potentially could benefit from the therapy. And that began to influence the discussion of the criteria that we proposed to California Children's Services. And what indeed we proposed as criteria for California Children's Services was that this would be, the therapy would be used for patients with an exon 51 amenable mutation, similar to the label. It would be used in patients who are age 4 and greater at this point in time, as safety studies below age 4 are forthcoming. Perhaps that those age criteria may be able to be expanded in the near future once some of these data are available. And then finally, that if either the percent predicted forced vital capacity was greater than 30% or the Brooks score was a 5 or better, i.e. the patients have some useful hand function present for use of adaptive technology such as a wheelchair drive system or computer mouse or computer device, then those patients could potentially benefit from EXONDYS 51, and that those patients, at least for the purposes of these initial criteria, those patients with an FVC less than 30% and a Brooks score of 6 would not likely benefit. And I think there's obviously discussions that would need to occur on a case-by-case basis, but I think the important thing for the discussions with MediCal and California Children's Services is they were uncomfortable with just a blanket authorization and using criteria that would just treat every single patient, because there might be patients where the risks might actually truly outweigh the potential benefits that could be achieved. And so I think that was important to the discussion with the leadership of MediCal. With that, I'll conclude, and we can certainly discuss some other particular points. I think the decision as to who should be treated is a very personal one between patients and their families and the treating clinician. But I think this is a start that at least gives Medicaid or MediCal leadership and third-party payers, at least some potential thoughts as to who this therapy might be useful for. So with that, I'll open it up to questions that perhaps, Pat, you may have or others.
Thank you, Craig. This was really terrific, Craig, and I so appreciate it. I think your thoughtful description and descriptors of going through the natural history is really compelling, and I think it's going to be very helpful for all the payers. I was especially pleased on I think it was slide 13, where you described that the presence of dystrophin from 2% to 100% really represents Becker muscular dystrophy, so that the mean change that we saw in dystrophin expression in the EXONDYS or Eteplirsen study was relevant and meaningful for these patients' lives. I was also particularly impressed with the natural history description of the comparators between Natalie Gomez and the Italian group, that the mean change in the 6-minute walk test was significant, and how you related that to meaningful quality of life and what that means in the life of the patient. And I fully agree with you that all discussions about what treatments are best for a given individual are based on benefit risk and best done in the setting with a clinician. So I really appreciate that, all of that. And I guess what else I'm wondering is in your discussions with MediCal, and I should preface this, and I am hopeful that payers and clinicians will watch this webinar and utilize it, because I think you have set a good example and certainly set criteria for this and all future interventions that will be approved, both drugs and biologics. So I guess one of the questions that I would have is, in your discussions with MediCal, were there specific issues that they really responded to and others that they responded to less?
Now, that's a great question, Pat. And I think what they were really looking for was, evidence-based, evidence-based criteria for use. And I think also what was quite striking is the flexibility that they would like to have in terms of pursuing this in the future. They're completely willing to change their criteria as more data become forthcoming. In addition, as in the case with some of the cystic fibrosis drugs, the California Children's Services Group, which is the Medicaid equivalent, the CCS actually manages the Medicaid patients in California in the form of MediCal. For the cystic fibrosis drugs, CCS actually maintains their own database with important endpoints over time, and they're actually evaluating their own data as to a registry, if you will, of patients treated in their state. So I think they were very interested in the possibility of following parameters such as the forced vital capacity and the performance of upper limb measures, or the Brooks score, or the 6-minute walk test, or the North Star, and data like that that would be maybe readily clinically available, as most of these patients are actually cared for at neuromuscular centers of excellence that typically obtain this type of data. So I think what really resonated, I think, with them was I think they were uncomfortable just with a blanket authorization. They wanted it to be evidence-based. They wanted to really focus on the patients who could potentially benefit from the drug first. But I think they'd like to maintain flexibility in the future, assessing data that becomes available, and perhaps even their own data on CCS patients that are treated in the state of California.
But it also sounds like, Craig, you made the case that even having some minimal arm function in FVC of 30% really does prolong both the ability to function, the quality of life, as well as the ability to breathe. So I think you made the case for the adults, which is something really, really important, I think, for our community. It sounds like they were very receptive to evidence-based and to include the adult population. So I guess what I wonder is, in this really terrific model you've created or developed with your colleagues, is there a way that we can, or you will be influencing or trying to discuss with other payers to use this very same model so that we can create a partnership with the payer community and all be interested in very similar outcome measures, such as 6-minute walk test, Brooks score, FVC, et cetera, so that we're all looking at all of these therapies that are on the horizon in the same way at the same time, so that this criteria can be an ongoing, informative, evidence-based registry, if you will, for patients on different treatments.
Yeah, absolutely. I think this is potentially a great model. I think involving the wider neuromuscular community of specialists, as well as families in these discussions, is essential. But I'm hopeful that other third-party payers will perhaps at least be open to the adoption of a similar approach or similar use of similar criteria. I think really being inclusive in terms of treating non-ambulatory patients that potentially could really benefit from these therapeutics in terms of preservation of their pulmonary function or their upper limb function. I know we have discussions planned for the neuromuscular and genetic specialists within the Kaiser system, which is the largest HMO healthcare system in California. And we're hopeful that Kaiser, which I think is very interested in evidence-based practice, will be at least open to consideration of similar criteria.
Good. Thanks, Craig. And so, Craig, do you also think that these same criteria, with the exception of dystrophin, should the approach not include a dystrophin restoration type therapy, could be modified to use with other drugs that are antifibrotic or anti-inflammatory or some of the anti-myostatins, so that we could develop this sort of uniform and very clear data collection system, so that we can very carefully and clearly see and understand what benefit looks like, and then patients and families and their clinicians can make these decisions based on evidence, but then the payers would be amenable to the coverage of the intervention.
Yeah, no, I think that's a great point, Pat. I think this model is used not just for dystrophin restoration, but with other therapeutic targets and agents as well. I think the one issue that will probably require greater complexity will be agents that might benefit both skeletal muscle and myocardium or cardiac muscle, because I think obviously our conceptually we'll have to discuss endpoints and clinically meaningful changes in terms of cardiac function and cardiac endpoints, in addition to the upper limb and the pulmonary endpoints in those specific agents that target the heart as well.
Yeah, thanks, Craig. I think that we had a meeting with the FDA, as you know, or the FDA attended a meeting about the cardiac outcomes, which is still a work in progress, as we know, because there weren't really any very agreed upon outcomes that could tell us about heart function. We talked about a range of things from the ejection fraction through the ventricular volume and around and all other possibilities. So I do think this is something that the clinical community and hopefully PPMD and the advocacy community can come together and talk about, so that we can add that to our repertoire as we're looking at targets that do target the heart, or for that matter, to cardioprotect boys, answering the question, if we're able to get them to walk longer, breathe longer, live longer, are we, in fact, we're going to need to protect that heart to a much greater degree than we are now.
Yeah, absolutely. I mean, it's great. It's great to see at least the progress that's been made with the scientific and advocacy community, as well as with the FDA fairly recently. I do think that also in my own clinical practice, I think I approach these discussions with each individual patient, at least using some of these natural history data and the concept of really providing families with information that can help them make decisions as to whether a therapy like EXONDYS 51 might be something they want to consider. For instance, if I am seeing a patient who has a forced vital capacity of 12%, who's on 24-hour-a-day mechanical ventilation, and they're using other assistive technology that perhaps they may not be able to access with their hand function, and those patients are understandably wondering whether EXONDYS 51 could be beneficial to them. In many patients, they may have elbow pushing contractures that could make IV access a problem. So you're talking about placement of a port for IV access, and these are the kinds of discussions then that I think a clinician can have with a patient and their family with regard to all those benefit considerations that are really very personal ones and that really need to be individualized to the patient.
Yeah, I agree, Craig. I think so many times as parents we read in the press about exciting opportunities, and often it's difficult to understand what questions do we need to ask, what do we need to be thinking about, what are the benefits and risks to a given intervention. So I think establishing this model and having the clinicians be aware of the model and having consistent talking points would be really useful and helpful to our families.
Yeah, and then I think the other point just to emphasize with regard to at least these criteria, which were developed by a number of neuromuscular is that they're very inclusive criteria. And I think really, the vast majority of patients probably would actually meet these criteria and have potential function that could be preserved by an exon skipping or a dystrophin restoration approach.
Yes, I'm sorry for the noise. I don't know what's going on here, but thank you, Craig. I totally agree. I totally agree that this really sets up the model for all sorts of therapies. So I can't thank you enough for this. And I think your interaction with the MediCal really sets the stage for everyone. As you know, there's considerable worry out there, and we've seen different payers come out with different criteria about assessing a patient in order to obtain EXONDYS 51, and likely more therapies as they're approved. So I really thank you for this webinar, and I'd like the opportunity to perhaps come back to you as we extend this and certainly include heart function within some of the interventions that are coming online.
Great. Well, it's been my pleasure, and thank you for the opportunity.
Thank you.